Corey Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast. It is October 2024. Ryan, happy Halloween.
Yes, happy Halloween. What were you this year or going to be this year?
Doctor Who.
Very good. Very nice.
Yeah, the Matt Smith version.
The Matts. Oh, okay. Yes, there are a wide variety of of Doctor Who's of various merit.
It's controversial as always, but he is the best Doctor.
The best Doctor.
Yeah, it might have been because Stephen Moffat was the showrunner at that time, and he was probably the best showrunner. But anyway.
Well, naturally, as you can see from his work on Sherlock.
Yes. Should we hop in?
Annals of Emergency Medicine.
All right, let's do it. All right, our first article is an adaptive, pragmatic, randomized controlled trial of emergency department acupuncture for acute musculoskeletal pain management. And the lead author is Stephanie Ecker. This is a look at acupuncture specifically in the emergency department. There is a fairly large body of literature outside the emergency department that has mixed results, some showing benefits, some showing no effect. But overall, it seems like there's a trend to that there might be some benefit to acupuncture when looked at against a sham control. But what these authors wanted to look at is its effectiveness and feasibility in an emergency department environment. And so they did an adaptive style trial where they essentially initially sought to figure out what style of acupuncture was the most feasible in the emergency department. And they essentially compared two styles of acupuncture. The first one was auricular acupuncture, where they take these really small needles and stick them in your ear. And the second one was what they called peripheral acupuncture, where they used a more community-based acupuncture, but restricted it to sites in the head, neck, and extremities, sort of sites that you could easily get to without having to expose the patient too much, because again, you're working in the emergency department. And they did a two-stage adaptive open label randomized controlled trial. The first stage was essentially identify which of these styles of acupuncture was more feasible in the emergency department. And then the second stage was, if they determined one style was more effective or more feasible than the other, was to compare that to a control group. So they rolled a convenient sample of patients, basically during 8-hour periods, typically somewhere in the daytime between 8 a.m. and 8 p.m., Monday through Friday. And they basically rolled adult patients with either new onset or exacerbation of chronic pain in the neck, back, arms, or legs. Licensed acupuncturists performed either auricular acupuncture or peripheral acupuncture, and patients were randomized to either auricular acupuncture, peripheral acupuncture, or usual care. Feasibility was assessed by patients' recruitment and retention rates, with a goal of an average of one patient enrolled per hour during the study period times. And acceptability was assessed by patient-reported satisfaction with the acupuncture treatment, with a goal of an average of 4 out of 5 Likert scale. The primary endpoint in stage 2 was change in current pain score from 0 to 10, from the study baseline to 1 hour after post-treatment. And they used the minimal clinical significant difference in pain score of 1.3, which has been validated many, many times. We've talked about this on previous podcasts. So following the interim analysis, they basically found that there was no real clear superiority of one type of acupuncture over the other. So in stage 2, they essentially kept both types of acupuncture, but randomized patients 2 to 2 to 1. So 2 patients to each form of acupuncture for one control. From February 10th, 2020 to May 3rd, 2021, they screened 911 patients and enrolled 236. Overall, the most common primary pain locations were lower back, followed by legs, followed by neck, followed by the remainder of the extremities. Most of the patients actually reported having more than one site of pain, and about half of them reported that their current pain was from a trauma or injury. The greatest pain reduction at 1 hour was observed in the auricular acupuncture group at 2.1 versus 0.5 in the control group. The only group that seemed to actually have a drop in pain score greater than the 1.3 that we considered clinically significant was the auricular acupuncture group. Interesting article. I think there's a number of limitations. Obviously, the first one is this trial wasn't blinded, right? And so there's obviously a good chance that there'll be a placebo effect here, as in the control group really didn't get any true form of control. I think the other big problem here is the post-baseline analgesia. So after the patients were enrolled, the control group, only about 35% of them received any form of pain medication, right? So it's not surprising that they really didn't have much change in their pain from baseline if most of them didn't actually receive any pain medication. So I mean, I think if you're going to actually kind of think about this and see if it actually is feasible and effective in the emergency department, one, you got to figure out a better control group, and two, we have to compare it to actually treating these patients' pain.
Yeah, I mean, I think that we've seen this over and over and over and over again, that there's these signals of benefit for alternative and complementary medicine therapies, but the difficulty is that just there's either no sham, no blinding. That's the big limitation. It's really hard to do like a sham acupuncture that is compelling. Like to actually have an acupuncturist go in there and do and like be intently shamming somebody. Versus when they're actually trying to do the real acupuncture. There's all this. It's really difficult to blind this appropriately for people. You can't double blind it because the person doing the procedure knows they're not doing acupuncture. It's just one of those. It's these trials are just fraught with bias, basically. The problem, with analgesia and that trajectory, if you don't get any pain medication beforehand, your trajectory is going to be different, and that's what they see here. I think they're just kind of separating out these sort of like these time frames, but it's almost artificial because they're not treating people's pain appropriately up front. So, I mean, I think the takeaway here is, and they kind of appropriately focus on this, is that it's feasible. You can do acupuncture in the emergency department. Should you is still totally an open question. Let us move on to our next article, which one is a comparison of nebulized ketamine to intravenous subdissociative dose ketamine for treating acute painful conditions in the emergency department. Our lead author here is Tommy Wynn, and they are at the Maimonides Medical Center. And again, it's ketamine time. It's the Emergency Medicine Journal. It's got to be about ketamine.
Ketamine, droperidol.
Ketamine, droperidol. It used to be dexmedetomidine used to be really popular, but that's kind of gone out of fashion recently, it seems like. But ketamine is never old. Oh, TXA. We forgot TXA is very popular. But in this episode of ketamine, you can either huff it or get that sweet, sweet vitamin K directly into your veins. And in one corner, you have, a reasonable 0.3 milligrams per kilogram of IV ketamine. And in the other corner, you get 0.75 milligrams per kilogram via breath-actuated nebulizer. And with 75 acutely painful conditions in adults in each group of this trial, the winner is, everyone. Generally speaking, everyone in each arm had some relief of pain, and the scope of reduction in pain was similar between groups, with mean pain scores in the 8s to start and the 3s within 15 minutes and steady through their 120-minute treatment period. So what I think you can generally take away from this is that nebulized ketamine is within the scope of reasonable practice for analgesia delivery. It will obviously be subject to the same disadvantages experienced with ketamine overall, and it may not be quite as efficacious as more patients in the nebulized group received rescue analgesia, but it is an option. And in emergency medicine, we never scoff at new and clever options for care in the emergency department. These data don't typically inform us as to whether this is the best nebulized or inhaled option, or how it is best utilized as part of your analgesic ladder, nor does it provide a comparison against usual care or placebo, and there is a significant Venn diagram overlap of patients with poor venous access and significant opiate tolerance, though, and I can see this as a reasonable potential option if you have that case. I'd be mildly curious to see how it compares to intranasal or intramuscular delivery routes, if we're thinking about using this as an IV sparing idea, or I can see it as a pre-hospital option as an alternative to, say, methoxyflurane if you're in one of those countries, or to nitrous oxide if you're, again, in one of those types of countries.
You're just lining up the next article perfectly. I think you're right. Without a control group, we're really just kind of deciding if ketamine can be given intranasally, which I think we have pretty good data on it can. And the limiting factor mostly is the amount of ketamine you can effectively deliver intranasally, which, is as much ketamine as you can fit into 2 cc's. So depending on your concentration of ketamine, you can get a quite high dose. And so it really is the weight of the patient versus the dose of the ketamine you can give is your limitation. But I think we already know that ketamine is fairly well absorbed intranasally. And so it's not surprising that you'll have pretty similar effects, either IV or intranasal. I do think these results are better than almost any trial we've seen at ketamine for controlling pain, either IV or intranasal. I mean, I've never seen a trial which showed ketamine this effective. Right? I mean, usually it has like a small amount of opioid sparing effects, nothing like this.
Oh, well, it's the future. These are the future. Ketamine, any way you want it. You can be dipped in ketamine. You can have it, applied liberally on your face like a mud mask or something like that. This is it. This is coming. Rectal enema, ketamine enema. We haven't explored that route yet.
Well, it's for next month. All right. staying on the ketamine train, our next article is actually just what Ryan suggested: pre-hospital intranasal ketamine as an adjunct to fentanyl for the treatment of acute pain in the pre-hospital environment. So these authors randomized patients pre-hospitally with acute pain to either receive either intranasal ketamine or placebo along with the fentanyl that they were treating these patients for their pain. And they were essentially randomized to either receive 50 milligrams of intranasal ketamine or placebo. So not weight-based, just a single dose. So your actual weight-based dose would really depend on the patient's weight. The primary outcome in this article, which is slightly different than the previous, was achieving at least a 2-point reduction in the verbal pain score from baseline at 30 minutes. And secondary outcomes were side effects, pain rating, and rescue medications. So overall, they enrolled 192 patients, 103 in the ketamine group and 89 in the placebo group. And unlike the last study, there was really no statistical difference in the proportion of patients experiencing an improvement in pain between the ketamine and the placebo groups: 44% in the ketamine group and 36% in the placebo. They really saw no difference as they looked at pain going out from 30 minutes to 60 minutes to 90 minutes, so on and so forth. So real intranasal ketamine didn't really seem to have an effect, at least statistically. Now, I do think this is slightly unfair. If you look at the 30 minutes post initial dose, you see numerically, it seems like the ketamine group did better. 45% of them had at least a 2-point drop in their pain score versus 36. So basically a 9% difference. Now, this wasn't statistically significant because it's a small cohort, and to get a statistically significant difference in a dichotomous outcome like this is fairly hard. Usually, these kind of studies use a drop in their pain scale, which is it's much easier to see a statistically significant difference when you're using a pain scale than when you're using a dichotomous outcome. In fact, compared to the previous study where they used the drop in the pain scale, which was much easier to show that kind of difference. So I wonder if they had actually used a drop in a pain scale, if we would have seen a difference in that first 30 minutes, where we know ketamine has some additional effect on pain score. But again, actually, contrast to the previous study, you really see a minority of patients in both groups actually having a substantial drop in pain, even with their fentanyl dosing within the first 30 minutes, which, we have to wonder how good we are treating patients' pain overall in this cohort.
Yeah, I mean, I guess that's our question: is it's an additive effect, and if you expect 100 micrograms of fentanyl, which is not a terrible dose, reasonably dose for a reasonably sized person, maybe not an American sized person, but a reasonably sized person, is a decent starting dose, and you're going to get some some decent analgesic effect from 100 micrograms of ketamine of fentanyl, and then you have to add on ketamine on top of that. So there's like kind of a dose response ceiling. Once somebody's pain is adequately controlled by fentanyl, how much extra are you going to get out of ketamine? So you're stacking the deck a little bit against ketamine having this profound magnitude or profound effect size. And then, are they using the correct dose of ketamine on top of it is the other question. Is 50 milligrams an appropriate dose for intranasal when the dose range could be anywhere from 0.5 to 1 milligram per kilogram if you want to get the best dose? It's just really hard to figure out exactly whether that's going to be an appropriate dose for your larger people. When you could, in theory, get the most maybe benefit out of it when you've underdosed them with weight-based fentanyl. So, I think there's probably some signal of benefit in here. If you say, is it more likely or not that ketamine has an additive effect? Well, it probably does. Is how clinically important is it? Are the side effects? Is the side effect profile useful versus the benefits? Or why not just give them another shot of fentanyl? It's like, why do you have to add ketamine in? So the real question is, why are you switching and adding in ketamine and getting this additional adverse effect profile when if somebody doesn't have a good response to their first dose of fentanyl, why don't you just give them little 25 and 50 microgram aliquots on top of it? Is ketamine better than that? So I think the question is not so much, is ketamine doing something? It's, is ketamine doing something better than what you could be doing in an alternative, which isn't tested here?
Right. And, especially, is it worth adding complexity to the pre-hospital environment?
Oh, always. It's the safest environment to have complex medical care.
Yeah, I mean, the other signal here that they probably weren't getting enough ketamine was like the side effect profile was essentially the same. Like there was a little bit more dizziness in the ketamine group, but outside of that, there really didn't seem to be a difference. And almost in every ketamine study where you see an effective pain, you've got that like otherworldliness and a little bit of dissociation that happens in a few patients that you just didn't see
it's
here.
working.
Yeah, so you really have to wonder what was going on here and were they actually getting, an actual clinical dose of ketamine.
Oh, right. Okay. So now from fun and ketamine to something totally not fun and not ketamine, but it's an interesting article nonetheless. It's called Measurement of Cost of Boarding in the Emergency Department Using Time-Driven Activity-Based Costing. Our lead author here is Maureen M. Canellis, and they're at the University of Massachusetts. And this is actually a study that's been picked up by the ASAP sort of newsletters and kind of bandied about a little bit. And it's kind of, we've gone on and on about boarding is bad for decades now. We know boarding increases mortality for patients in the ED as opposed to the inpatient ward. And that's without even considering the opportunity costs for patients whose care is delayed waiting for that bed space. However, it does sometimes seem as though that patient oriented outcome falls in deaf ears in an era where revenue oriented outcomes are more important. Well, so here's a little study trying to speak that proper language, looking at the total costs for patients who remain in the emergency department rather than being admitted to the hospital. Their methods are a little bit oblique. They looked at code stroke patients specifically because of their high likelihood of admission, and then used their sort of in ED resource utilization as a sort of surrogate for the intensity of cares necessary for that prospective inpatient admission. They created this process mapping and performed direct observation of time devoted to patient care activities to estimate the operational costs associated with these patients. And then they did this, they based this on observations of 25 qualifying code stroke activations. And they found that the cost of the inpatient care activities performed in the ED at their specific institution was about $1,800 per admission here for ward level care per day, and $2,267 for ICU level care. And these estimates could vary depending on the hourly costs of different care team members. For example, if they were traveler nurse shifts versus salary shifts, they could shift there was a whole bunch of ways they could shift their models around. So these ED costs, however much it costs to care in the ED, was greater than it costs to be in the inpatient wards, and effectively similar to being an inpatient ICU sort of level of resource utilization and cost. It is still a bit hard to figure out how to interpret these data, however, because part of the costs of care were also attributed to the inpatient team rounding times coming into the emergency department, which doesn't really come out of that ED resource bucket for care and costs. I'd also somewhat critique that these quote unquote ICU patients from code stroke activations are good proxies for other ICU patients because some of these quote unquote critically ill patients were discharged from the ED directly after boarding. I think this is probably one of those things where anybody who gets thrombolytics is quote unquote goes to the ICU for observation, whereas that's not the case at every hospital. So I'm not exactly sure how this supports efforts to move boarding patients out of the ED other than the superficial sort of like newsworthy bullet points. It certainly costs time to have ED nurses and clinicians providing ongoing care for inpatients. But where revenue is truly being subtracted from the hospital is the opportunity cost of the occupied ED bed. The revenue question becomes whether the inpatient beds are being occupied by higher revenue patients, say those post-operative patients for elective joint or cardiovascular or neurosurgical procedures, justifying the billable charges a bed space in the ED might generate over the course of the day. So, like, if it costs some money, yes, to put them in the ED, but if they have a much more revenue generating patient in the hospital, then the hospital still wins. So I'm not that's where I'm unsure where this helps our argument necessarily. So a bit of an interesting idea, but I'd just probably say it doesn't really provide a reliably complete look at the problem in the full context.
Yeah, I mean, I think that last point is key, right? It is where are they saving the money somewhere else? Because that's usually the case, right? Whereas it might cost a little bit more to manage these patients in the emergency department, usually that's happening because either someone else is occupying the bed on the floor, which is making the hospital more money, or it costs too much to open the extra ward, get the extra nurse, and get the extra staffing, so on and so forth, and it's cheaper to manage the person in the emergency department.
Yeah, and the hospital still gets paid. There's
Exactly.
money coming in. The hospital, there's still a bill of admission, and depending on whether it's a capitated DRG type diagnosis thing or whether they're getting paid like for individual procedures and things like that, all those things are still getting captured in the emergency department. So the hospital still gets paid. But yeah, like somebody who just had a coiling procedure and got to activate, in the endovascular lab for $50,000 or whatever, $100,000, and that's a lot more than the $1,800 it's gonna get the hospital for cost them for keeping keeping the patient in the emergency department. So, or whatever cost, whatever small revenue difference it might be, and then against the patient who's still stuck waiting to be seen, there's how much revenue can you extract from that next patient who might have been seen? It's hard to say, because we're pretty good about triaging the sickest, most interesting, and probably the most complex and revenue generating patients back to be seen immediately, and it's the less rewarding patients who get to wait longer, and from a revenue standpoint.
Yeah, I mean, this stuff is usually happening for a reason. The system is perfectly designed to get the results that it gets, right? And so, um,
But it's a good idea
yeah,
to try
it's
and speak
just
their language, but I'm not sure it actually works in our favor.
yeah, and it doesn't tell the whole story, unfortunately. All right, our next article: rapid acute coronary syndrome evaluation over 1 hour with high sensitivity cardiac troponin, a U.S.-based step wedge randomized trial. So, like ketamine, we are now again talking about high sensitivity troponins. And once again, we're going to take a look at it, though this takes a slightly different perspective than what we've done in the past. In this case, the authors basically at their
The 60 authors
yeah,
or
at
so.
60 doctors, 9 emergency departments. Essentially, they adopted a high sensitivity troponin, and they decided to roll out a rapid diagnostic or rule out strategy over across their 9 emergency departments, and to look at outcomes from that. And so they basically had 2 protocols. The first, the standard protocol, which was prior to this rollout, they already had their high sensitivity troponin, but they hadn't actually rolled out this rapid screening process that they were planning on doing. So prior to that, basically you had your high sensitivity troponin, and patients could be ruled out with a non-diagnostic EKG and a high sensitivity troponin below the 99th percentile, which in this case was 18 nanograms per liter at 0 or at presentation, and then 3 hours. But to discharge the patient, you had to have this negative troponin and then a heart score or a modified heart score less than 4. For those of you wondering, the difference between the heart score and the modified heart score is the modified heart score now takes into account the high sensitivity troponin rather than the heart score, which was the 4th generation troponin. Otherwise, it functions exactly the same. In their rapid protocol, patients could be excluded from MI in 3 ways. They could have a troponin within the first hour that was in the undetectable range or less than 3. And if this was the case, they didn't need to apply the heart score. The patient could be discharged home. In patients who had a troponin that was over the level of detectability or greater than 3, then the patients went on to the 3-hour troponin. And if the 3-hour troponin, much like the previous score, was less than 18, and they had a heart score or modified heart score less than 4, you then could discharge the patient. And for patients with a troponin greater than 18, they had to be admitted to the hospital for further workup, right? And so it's essentially the rapid rule out strategy just added a 1-hour measurement below the level of detection. And if that was negative, they could be discharged faster. So they essentially studied people from July 8th, 2020 to April 3rd, 2021. And they enrolled over 32,000 patients in this. And remember, the way they randomized was essentially they stratified when each of their hospitals would adopt this rapid rule out strategy. And it kind of one after the other. And so it was essentially a before and after look at this with the randomization of when the hospitals started to incorporate the rapid rule out strategy. Essentially, the amount of patients that were discharged between these 2 groups didn't differ: 58% in the rapid rule out strategy and 57% in the standard strategy. So no real difference between the 2 groups. There was also really no difference in the amount of missed MIs or any of the other findings here. And so this sort of differs slightly from previous looks at high sensitivity troponin. And I think it's really based on the design of the study. Most of the other studies looking at high sensitivity troponin compared them to a 4th generation troponin and a heart score, and basically showed that you could more rapidly discharge patients from the emergency department. Though again, the difference in the number of patients you discharged was essentially minimal, and the amount of MIs that were missed were essentially no difference between the 2 groups. In this case, both groups were using the high sensitivity troponin. And if you just looked at the amount of patients that you could discharge from the emergency department, it would essentially end up being the same, because you might have discharged a few earlier in the rapid group, but the ones you couldn't discharge in the rapid group then just fell into the standard score, and you either ended up being able to discharge them based on their troponin and their heart score, or they had to come into the hospital. And so it's not surprising that when you give people this kind of work strategy or this pathway, you're pretty much going to end up with the same results on both sides.
Yeah, I mean, it's just a question of how long they're in the emergency department. So, I mean, yes, it's more rapid turnaround potentially for a subset of these patients versus the 0 and 3 hour protocols. But yet again, there's so few primary outcomes in both groups. It's one of those things where you could almost imagine you just closed your eyes, didn't look at any results, and just sent them away. Almost, and everybody did fine. Whether you had like if you had a non-ischemic ECG and a single troponin, done, and they're probably all going to do fine. It's our troponins are so sensitive now for even the slightest bit of troponin leak. Which makes them unfortunately very non-specific, and you get all these weird intermediate zones that generate this downstream testing. But we have talked about that about a zillion times on this podcast. This is fine. I mean, it just shows that you can change your troponin protocols. It can have appropriate diffusion and uptake, and you potentially and they decrease your ED length of stay based on it. Great. All right. Done.
One of the things that I find is interesting is the modified heart score. I thought, I've spoken, I would say, skeptically and maybe negatively about high sensitivities on most of our conversations on this. But I thought the one good thing that the high sensitivity troponin did was get rid of the heart score. And now it's being brought back. I thought the data is pretty clear that a negative high sensitivity troponin is fairly good at risk stratifying you, that you no longer need the heart score. Now, if you actually look at and read the heart score data, there are a number of trials looking that you can discharge patients with heart scores up to 6 with negative troponins and negative EKGs. Even
because
the old
once you get over 6, you've got a positive troponin.
Right, exactly. Yeah. So essentially, what that meant was the things in the heart score that mattered was the EKG and the troponin. So it's not surprising that you didn't need it anymore. But I thought the one advantage of the high sensitivity is we no longer have to deal with the heart score, though it seems like we're bringing it back.
Well, maybe you are, but we have not been using a risk stratification engine to supplement our troponin scoring at our hospital for at least a few years now. It is used in determining what sort of follow-up patients might get for, either provocative studies or for cardiology consults, virtual consults, and things like that. But not for ruling out acute coronary syndrome. I mean, you're done. You're done from acute coronary syndrome standpoint, and then everything else is just trying to safety net people.
Yeah, our protocol.
So you don't need the heart score to safety net people. You need the heart score to figure out your safety net potentially. But as far as ruling out people in the emergency department, troponin is all you need.
Yeah, I mean, if you have a negative troponin, so below the 99th percentile, at 3 hours, you essentially go home and you follow up as an outpatient. So we don't use the heart score at all.
Well, we can shout it from the rooftops here, and maybe people will listen. All of our listeners will listen anyways. All right. Let's see. Are we closing it out here? Yes. The last article we're going to talk about from this issue is called Rapid Electroencephalography and Artificial Intelligence in the Detection and Management of Non-Convulsive Seizures.
There had to be an A article. There would not be a podcast without an AI article.
It is the future, Rory, is artificial intelligence. You know this, right? Do you get to use an LLM? Do you have digital scribes?
No, this is the one thing I'm pretty passionate about with AI is if the AI could write my notes for me.
Yeah, you still don't have it.
No, still don't have it.
Oh, geez. You can actually open source it, but I guess if your hospital has a policy, then you can't use it. There's like lots of little like products you can buy for like $70 to $100 a month kind of thing, just on the side. But if your hospital's got a policy of not using those, then you're up a creek. So the lead author here is Chase Richard, and they're at the University of California, Los Angeles. And this is a very brief report on the deployment of an EEG device in the emergency department, proposing to improve and expedite the diagnosis of non-convulsive status epilepticus in patients with undifferentiated mental status change. In this specific report, approximately a year's worth of use of this rapid EEG device is described. The indications for which simply involve the emergency physician's suspicion for non-convulsive status epilepticus, as guided by appropriate clinical indications. The company producing this device provides an AI interpretation for the EEG findings, presumably allowing for autonomous use to augment clinicians if real-time EEG support is not contemporaneously available. There were 108 patients in their cohort whose EEG findings were interpreted by both the AI and the on-call epileptologists. And, well, as with just about everything AI related, there is work to be done. Um, there were 3 cases adjudicated by the gold standard epileptologists as seizure activity out of these 108. And the AI said 2 of those were definite seizures, and the other one was probably likely 50 to 90% sort of seizure activity, visualized activity consistent with seizure. So they almost caught the seizures. But it also classified another 3 patients as being in status and another 5 as being likely high seizure burden. So obviously false positives in far greater numbers than the true positives. Obviously a real issue when dealing with a very low prevalence condition like non-convulsive status. The diagnosis of non-convulsive status epilepticus is certainly challenging to make and important to either confirm or exclude in that critically ill patient with known epilepsy or an underlying condition potentially predisposing to seizures, but intubated, paralyzed, what have you. But at this point, this sort of technology, just a glimpse of the future, still years to go before one of these shows up in your emergency department.
Yeah, it's a great idea because, like, even when you work at like the receiving center, of neuro excellence, and you can get well, first you need a technician to come in and get set up your EEG. You can get your EEG set up. It's hours before the epileptologist can actually read your EEG findings, and so you you can develop some skills to be able to read your own EEGs. It's much like EKGs; you just look at it and you get better at it over time. Um, but this would be great if it worked. But like you said,
Yeah, there you go.
this is nowhere.
It's AI. This would be great if it worked.
It's nowhere near close enough to it. You can't.
But we're saying this today. Give it to November 2025. We'll be saying, "Hey, look, it's back, and it's a whole lot better." And then we'll be like 2028, and we'll be like, "Yeah, deploying your as you would routinely in the emergency department, deploying your EEG caps to get the automated AI to look at it."
I was surprised that there was that many seizures out of 108 patients. Yeah, it's almost always diffuse slowing. I think if you looked at our yield in the ICU, it would be less than that.
Well, I mean, you could see who they selected. They selected patients who had a seizure disorder and maybe even presented and got intubated because they were having seizures and lost their airway and never recovered and didn't have, they were in status basically. So a status patient who's paralyzed, who was in status, sometimes is still in status. So I think they had a very enriched population, which again shows us how this would actually function in the real world. If it was just something you could just grab any time, you'd be diagnosing status, hordes of patients who are nowhere close to it.
Interesting idea, nonetheless, right? All right. Well, it's good to know we're not fully replaceable yet.
Well, somebody's always got to collect the data for the AI.
Skynet.
Somebody's got to push them to radiology. Still need a human for that. Well, not for long though. Autonomous stretchers are coming.
Yeah, Skynet will be here soon.
Well, they just need to have it by the time we're old. So they just got to get it all perfected by the time we're old, and there are no more medical errors. That's our race because we're not old yet. Right?
Well, yeah, I was about to say. I think our children might say differently.
All right.
I think that wraps up yet another month.
At all, November.
Any comments, questions, or concerns, we can be reached at annalsaudio@acep.org. Until next month, this was Rory Spiegel and Ryan Hideki, and this was the Annals of Emergency Medicine Podcast.